So I'm Gordon. I'm a statistician down here in Exeter, and I'm also director of the Research Design Service for the Southwest. And my thanks go to Adateo, who really came up with the. I've adapted their presentation for this. So this is about how to present really statistics in your application. And I sort of subtitled this, it's more than just sample size. And I suppose I would like to start by saying that, you know, if your statistician only wants to deal with the sample size and nothing else, then you probably need to find another statistician, because, you know, I think you need a statistician, unless it's a purely qualitative project, actually throughout, throughout every aspect of the development of your application. Okay, so let's go from there. Well, you know, so in terms of statistics, where to put it, a bit of study design, analysis, and then I'm calling a final section there, don't be a stranger. So the statistics section, well, to start with, there is no single statistics section or single section that should just have your statistics in them. You really need statistics throughout the application. You know, that may be at the start about, you know, how prevalent the condition is, how many people, you know, how much of a problem is, etc., all the way through to the end, to analysis, and, you know, and through to dissemination. So statistics is throughout the application. And I think, as we've heard in a number of presentations, both today and yesterday, is that one of the problems with any application is that there's never enough words. Okay, so I think it's always a balancing act. And I think a lot of this is just getting that balancing act right in terms of the amount of statistics you're going to put in your application. So in terms of what the statistics will look like, well, you know, they may be different if it's an NIHR application as opposed to an application to a charity. And certainly even within NIHR, you know, the different funding streams really require a different level of, a different level of statistics in the application. So an HT application, again, would look very different from an IFRI application in terms of statistics you'd want to include. There's also stuff about, you know, the actual type of study you're doing. So again, feasibility trials tend to have different levels of statistics. You know, you wouldn't want quite as much statistics in there as you would perhaps if you're doing a full effectiveness type study. Okay, really just to conclude this bit by saying, well, you know, even though the focus and details may be different, I suppose the principles fortunately are the same. So we can look at those principles. And the first one of those is about the type of study. I mean, it's again, you know, this does come down to the number of words you've got. And I think it's always good to make it very clear the type of study you're doing. So, you know, is your study an observational study or is it an interventional study? I suspect most of the work that's going to NIHR would be interventional type studies, as that tends to be what they want to focus on. But, you know, do make it clear which one it is. So an example of an observational study here, there we are, association between nurse-reported hospital characteristics and estimated 30-day survival. So no actual intervention there, just looking at those associations, looking at what's going on, as opposed to our second one here, continuity of care by a midwife, primary midwife, caseload midwife increases women's satisfaction with antenatal, interpartum and postpartum care. So this is the Cosmos trial, and here there's a comparison. There's a comparison between two groups there. So if it's a comparison, it's an experimental type study, or it's a randomized controlled trial. It's an experimental study. I've also pointed out here, I haven't got a slide on it. I think if you can, it's good to also just try and pigeonhole exactly what type of study it is. So this is specified as a randomized controlled trial. If you can say that, say that. You know, if it's a platform trial, say it's a platform trial. Whatever type of trial you're doing, you know, again, make it clear to the reviewers exactly what you're doing. But also do get it right as well. And I think, you know, lots of people, for instance, quite often confuse case control studies with cohort studies. But, you know, do know what sort of design you're doing. I'm sure you've hopefully all seen this before. This is the PICO framework, a very widely used framework for identifying, well, really for developing research questions. So this says, well, you know, what are the important elements of any study? It's about the population you're interested in. It's about the actual intervention they're getting. It's about the comparison. and again about the outcomes you're going to measure when you're going to measure them. Interesting, what I do occasionally see people missing is actually this comparison. So I think people often become so focused on the intervention that they're interested in, they actually forget to tell us, what the alternative is, what your control is. So please don't forget that control group, because it's that comparison you're making against that group that actually is the important comparison. In terms of design, well, randomization is a fundamental aspect of randomized control trials. I've had more time to talk today. We could, spend some time discussing why we randomize. And I do think that's quite interesting. How is it that, adding this extra bit of variability helps, and actually makes things better? Well, a bit of history. So before we had randomized control trials, or before randomization, they used to use a method of alternation where, the first patient for the trial would get, I don't know, be in arm A, and the next patient would then be in B, and then they'd go back to A and next to B. And what did they find? Well, they found that people recruiting, they would look at the patient and say, well, this patient's going to get into group A, but I don't think group A is very appropriate for them, so I won't randomize them I won't enter them into the trial. And hence they bias the trial. So this idea that actually by randomizing and by nobody knowing what group somebody's going to go into, we get a fair comparison at fair groups at the start, following them forward to the end, and then we can be fairly confident that any effects going on is due to the intervention itself. Of course, that only actually works in large trials, and actually you can get quite significant variability between groups if trials are not very big. Okay, so the other aspect I briefly mentioned there was blinding. This again, will actually knowing what group someone is in can actually influence the actual outcome they get. And again, I've been in sort of trials of exercise interventions, and you sort of get the feeling that if the assessors knew which group a patient was in, it may just marginally influence how they would treat that patient when they were undergoing there may be the time to get up and go and all those sort of tests. They may just, for those patients that are in the control group and didn't get the intervention, they may not make them work just that little bit quite as hard. They might not give them quite the same motivation as they would for the patients in the wonderful new treatment that everyone hopes is going to change everything. So if there's any potential that somebody can influence the outcome, then really they should be blind to the effect. And I have to say, if I'm analysing the results, actually out of preference, I would rather not know which is the which is the intervention group and which is the control group, because again, I as a statistician feel as part of the analysis actually under pressure to find that the new treatment is better, because I know that everyone on the team wants that. So do think about who could actually have those effects. Well, probably what most people come to see us for as a statistician is about this idea of sample size. And I'm sure you'll be glad to hear that I certainly don't intend to go through any calculations of sample sizes today with you. But I would say, to start with, do get the calculations right. It's amazing, statisticians on the committees will see if they can replicate the sample size calculations. And it's amazing how often the sample size calculations can't be replicated when they're on the committee. And actually, that's actually, well, going to be a black mark against your application. So do get it right. Do be clear how you did the sample size calculation. So what's important? Well, I suppose there is, how many participants are actually available for recruitment. It's pointless coming up with a sample size that you're never going to be able to recruit. So do think of that. I think the main thing though we need to think about is this idea of what's clinically important. So what's a clinically meaningful difference between the group? And can you actually evidence that as a good size of difference you actually wish to see? And then beyond that, well, there's this sort of significance. Actually, that's fairly standard, fairly set. We talk about 5% significance. We talk about ideally 90% power, possibly 80% power if we can't do 90. But those are fairly set. And then, you know, please don't forget to actually think about what you're going to do about missing values as well, you know, because, you know, it is about how many valuable patients you have at the end for your analysis. Okay, I mean, I think the other thing I would say here is that, you know, in terms of getting the calculations right and in terms of leaving it to the statistician, is that this clinical importance bit is not really something for the statistician to work on. It's really a clinical or, you know, clinical thing. So, you know, don't leave all your sample size to the statistician. Do check that actually this size of difference that you're looking at between the groups is actually reasonable and is an important clinical difference. Okay, so on to analysis. Well, so probably the standard type analysis for randomized control trials that are looking for a difference between groups is this idea of an intention to treat analysis. And this is where basically you analyze a patient according to the group they were randomized into, even if they don't receive any of that intervention. Okay, I'll say that again because sometimes that surprises people. So it doesn't matter if you're getting the intervention or not. It's just the fact that you are allocated to that group in the first place. You know, if you're allocated to the intervention group and you actually got the control group, you're still treated in the analysis as if you were, as if you're in that first group you're allocated to. Okay, because that's the only way of avoiding this chance of bias creeping into the study. Also, if you think about what happens when you do that, you know, what you're really doing is you're minimizing any difference between the groups. So if you can minimize the difference between the groups and still find them statistically significant, then you can be fairly confident that your result is, you know, is a true result. So there are some other types of analysis that we occasionally do. The first one there being a per protocol analysis. And this is where, well, you know, basically we analyze the patients who actually completed the protocol, actually did what they were meant to do in the study. The problem with this is obviously that, well, you know, they may not be, it may show you potentially how good the treatment could be, but they may not be your average patient, you know, because if lots of people are falling out of one arm because they can't do it and not out of the other, then again, it may look like your treatment is wonderful, but it's just that all those that didn't find the treatment wonderful have dropped out of the study, so you haven't got a fair comparison. And the final one there is sort of as treated analysis. You might occasionally get these in sort of surgical type trials where, I don't know, you know, if you're doing a replacement hip, then, you know, frankly, you probably use the hip that's there and that's available. You can't wait for another one to appear. But again, the problem here is you're really getting round the whole randomization thing. So the randomization is no longer relevant. So there's a possibility of actual bias entering into the study. Okay, so in terms of the analysis itself, I mean, again, I think you just want to try and be as clear as you can possibly be about how you're going to actually do this analysis. You're trying to convince these reviewers that you know what you're doing and you can do this. You can do this study. You know, you don't want any question in their mind about the fact that they might get to the end and actually not know how to analyze these results. So, you know, do give as much information as you can about that. But again, you know, as per the last speaker, I'm very aware there's not many words to do any of this. So it is about, you know, getting that right and writing as succinctly as possible, but also being really clear about what you're going to do. Okay, and I suppose in relation to that, well, you know, again, to do a good study, it's good to check some of your assumptions around it. So, you know, even when you've done your analysis, have a sort of plan B for the analysis. It's just checking those assumptions and just giving some sort of sensitivity analysis about your results, you know, so that you can be really confident in the results you get from your study. And again, just really to say at the end, certainly within NIHR, any proposal isn't about an individual, unless maybe it's a fellowship. But, you know, most proposals to NIHR are about a team activity. So, you know, do ask a statistician, do get a statistician on board to be part of your team. Okay, thank you.
Thank you very much.